Hello everybody and welcome to your Neurological Vital Signs lecture. This is an extension of the vital signs content and height and weight content that you're going to find in the module. I separated it into a little bit of a smaller PowerPoint just for this specific kind because neurological vital signs are a little bit different. So, a basic examination of the neurological system. What are neurological vital signs and what is this basic examination? There is a more extensive, I would say, assessment of the neurosystem you're going to be learning when you go to Skills 3. Right now, we are doing a very basic assessment in the Skills 2 to give you an early idea of the types of assessments that we can use to specifically assess abnormalities, complications, concerns in the neurological function of our patients. The three main things that you are going to be assessing are eye-opening, verbal response, and motor response of your patient. These three things have some normal findings that we should find in an intact neurosystem. If there is something happening, then one, two, or all three of these pieces of the assessment could show some abnormal findings. When we go further on, you're actually going to be, I believe it is in Skills 3 again, you will be trained in how to use the Glasgow Coma Scale. This assessment here is basically the Glasgow Coma Scale that you would give your patient numbers, a score, and from that again treatment would be determined. For this level of skills, we are basically just using it as a tool without the formal Glasgow Coma Scale being filled in. So for those of you that are a little familiar with the GCS, you may sort of see this and think, oh, this looks familiar. So what are we assessing in these pieces? First of all, eye-opening. This assesses the patient's level of consciousness. And eye-opening should be spontaneous. You're going to be, You're going to be noticing spontaneous eye-opening as soon as you enter a room, really. A patient is, even if they're napping, they may hear you and they may open their eyes to look at you. You may walk in and call their name, say, "Good morning, Mr. Smith," and he opens his eyes. That is what we are assessing. And how conscious is the brain? How awake is the brain? So spontaneously is a word we would use when we're not introducing any stimuli to the patient to wake up. They're opening their eyes to what they're hearing in the environment. They're waking up on their own to an alarm. They're just waking up on their own when their body is done sleeping. That's spontaneous. Then we get into little things like, okay, I've walked into the room, I'm walking towards the bedside, they're not responding to me, but then when I speak their name, "Good morning, Kim," and I open my eyes, well, they are now eye-opening in response to speech is how we would do that. The next level of that would be, okay, I've walked into the room, they didn't open their eyes. I called their name. They didn't open their eyes. The next thing we're going to do is kind of initiate a pain response. Now, you're not going to go pinchy pinch them. And pain response really, we got to be a little bit critically thinking here. You're going to touch them. You're going to poke them. You're going to say, hello. You're going to touch them. If they're still not waking up, you might have to give them a little pinch, all the way to doing a little rub on their collarbones, their sternum, to initiate eye opening. Sometimes you'll do that and they'll go back to sleep. But again, that is showing you a different level of consciousness of the brain. So they're in there. We've stimulated a pain or touch response, and they've opened their eyes, but they're not maintaining alertness, awakeness. And then, of course, the last one, which we'd be very concerned about, through 2 and 1, there's no response at all, that we're not getting anything from them. So that's what we do with eye-opening. This is assessing the level of consciousness or the awakeness of the brain. Is it spontaneous? Do we have to speak to them to get them to acknowledge? Do we have to do a touch or a pain stimulus? And then ultimately, is there no response? The second one is verbal response, and that's not our verbal response. That's the patient's verbal response. So when you are speaking to them and asking them questions, is their verbal response appropriate? And what we're looking for here is potential confusion and the quality of speech. Again, indicating brain function. So we're going to be talking in another slide or so about orientation status. We're going to be asking them 3 questions, and we're going to be determining, do they know the time? Do they know themselves, which is person? Do they know the place? That is 1. And we usually say they're orientated. If any 1 or 2 or all of those pieces are not answered correctly, we would then determine that the patient has confusion. From that, we also want to be assessing inappropriate words, meaning, are they handing you their water bottle and saying, could you please fill my bowl? Okay, so they've named the water bottle something different. Or they may say, it's nice to see you. Oh, that came out wrong. That would be time. Inappropriate words. Like I've had patients, they'll start to talk to me, say, yes, I had breakfast this morning and I had a cow. And when really what they had maybe was, a piece of meat, but they'll call it the animal. Do you see what I'm saying? Or they may say things like, I had, you'll see a lot with, they'll alter the name. So instead of milk, they may say white water. Like they're using the wrong words, inappropriate words, or inappropriate descriptions, or trying to describe something and it's still not coming out right. All of these indicate a level of confusion and an impairment in speech from the brain to where our voice box, where we're supposed to be transmitting our communication. We then would go to a verbal response of incomprehensible sounds. This is very sad to see, but they're trying to speak and it's not coming out. You're getting muffled sounds, you're getting groans, you're getting moans, you're getting all kinds of sort of guttural sounds, squeaks. They're trying to speak and it's not coming out. And then right down to no response. They're verbally not answering you. Again, verbal response will help us to determine their confusion level and their quality of speech. So we're going to be checking orientation status to time, person, and place, or person, place, and time is what I'm used to saying. We're going to be checking for confusion, and our orientation status will usually give us that indicator. Inappropriate words, which may lead to incomprehensible sounds, and you can have a mix of 3 and 2, and then no response at all. And then the last assessment we're going to do in our basic exam of the neurosystem is motor response. Motor response is doing a couple of things. It is assessing a little bit the musculoskeletal system, but how the brain is talking to the musculoskeletal system in order to move. And we're doing extremity assessments when we do this. So motor response, we're assessing the ability to understand and comprehend, because we're going to be giving the patient some commands to see if they can follow those commands and follow through correctly. It's also about making purposeful movements, not involuntary movements. That's another test. And then we're also assessing for weakness. So there's 3 things with the motor response. And how are we going to do that? First of all, Kim, can you just lift your arm over your head? So I did. I obeyed a command. Kim, could you blink your eyes for me? Kim, can you stick your tongue out? You know, Kim, can you pull up your blankets? Whatever it is, it doesn't matter. I always use their name. That's just something I was trained to do. Don't feel you have to, but I find that also focuses on the patient, because sometimes they don't think you're talking to them, and sometimes the patient in the bed beside you is answering you. And sometimes even if you use the patient's name, the person in the next bed will answer you. But I find just when we're obeying commands, I like to use their name. So the next thing would be, okay, you know, we want to watch too, do they move from localized pain? That is something that, okay, they're not obeying commands, they're not really looking at me, but if I kind of give them a little poke or a little pinch, are they moving away from me? Does that startle them? Excuse me. My allergies have not been kind to me the last 2 days. So we're going to be noticing that. You don't follow commands, but guess what? If I give them a little stimulus, they do respond to pain. Sometimes just putting the blood pressure cuff on, you can assess that as well, because that's a discomfort. And are they reflexing from the pain? Are they withdrawing from the pain? The other thing that we're going to teach you is, do they have good flexion and extension of their extremities? So again, can they extend them well, flex them well? The same with the legs. You know, can they bend their knee up, down, or you can take them for a walk and see if they've got good extension for those. And I'm going to talk about strength and muscle strength here in the next one. But these are the three main things. And I think you can understand with eye-opening response, we're checking for awakeness and alertness. Verbal response, we're using that tool to assess level of confusion and their ability to process and speak out what they're supposed to. And then motor response is testing their ability to follow commands and that the muscles and the joints are doing what they're supposed to and they're talking to the brain. That's very layman's terms, but that's what those three areas. So you must know, and we're going to practice in lab, eye-opening, verbal response, motor response, and the things that you do within those to do your assessment. So PERLA. PERLA is another piece of the neurological assessment you will be doing. This is when we shine a light in our patient's eye. And we're doing some specific assessments when we do this. So first of all, we'll go down here. The PERLA acronym stands for pupils are equal, round, reactive to light, and accommodation. So there's 2 R's. PERLA. You are assessing all of those things while you're doing your light, introducing your light onto the pupil. Normally, and this is what's up in this top box, normally, if there is no impairment, what is going to happen is, and what I should say before you put light in, like extra light, normal, I'm sitting here, our pupils, so this is the dark center of our eye, you have the sclera, the white, you have the colored iris, and then you have the dark little circle in the middle of your eye. The size, shape, and symmetry of both pupils should be the same when a human does not have a neurological impairment. That's an expected finding, okay? So size, shape, and symmetry, meaning the equalness, should be the same. Each pupil should constrict briskly, which means as soon as light hits it, it should react. when a light is shined into the eyes. So that's an expected finding, and that would be bilaterally. So they should constrict briskly, and each pupil should have a consensual light reflex, and I'm going to explain what that means. So each pupil should have a consensual light reflex. So these are your normal findings. Still didn't get my pen out to write. I'm doing it with my mouse. How beautiful is that? But these are your normal findings. So in order to determine normal or abnormal status, we are going to follow the acronym PERLA, and we are going to assess each of the pieces of the acronym while we're flashing our light. So the other thing to highlight here, not only is a PERLA assessment checking neurological status, it is also checking ophthalmic status. So eye muscles and the optic nerve to the eye. So that is also being assessed as well. Some of the findings that we have may be more directly related to specifics of the eyeball and structures itself rather than a direct brain relation. Okay, so when we're doing this, we are 100% assessing neurological and ophthalmic status. You need to know that. You also need to know what those stand for, and you also need to know what you're assessing when you do the PERLAs. So the first thing, P, pupils. Normal pupils are generally equal in size. And I'm just going to slip over here to my pen light. I apologize as I'm still talking. Normally, a person who does not have a light shining in their eye, or they're not in the dark, or just going around doing our everyday stuff, normal pupil size tends to be 2 to 3 millimeters, and we measure it in millimeters. I don't know if any of you have bought a pen light yet, and I think I might have mentioned, but my pen lights that I've always bought, I always make sure that there's a pupil gauge on it for me, okay? And on the side below it, you will see it tells you what size that is. This is wonderful to have, especially at the bedside, because as you're shining in, you're noticing, oh, you know, they're 3 millimeters when I am, is my light working good? They're 3 millimeters when there's no light trigger, and they'll go down to 1 millimeter when I flash the light in. I'm going to take my glasses off here too, by the way. If a patient has glasses, you should do it without it. Depending on their prescription, you may have, that may cause some discomfort, but it's also going to alter your findings. So just to let you know, it should really have the glasses off. The patient does not have to see for you to do this, okay? So as you're doing your light reflex, you've got your gauge right there to look at, and you can do the measuring. You know, I hold it so that my gauge I can see, and I'm watching as I go, and you can easily do a measurement. Okay? That's my advice for you. Or somehow find a little pocket gauge that you can carry. You can get all kinds of nice little nurse's notes, bare minimum. And I used to do this before our pen lights came fancy. I literally would draw on my worksheet a dark circle the size of the pupil. I know that's geeky, but it worked. And then I'd go out and find a measuring tape, because you're not going to take a measuring tape to your patient's eye and be doing that. That's just not what you're going to do, because you can't hold a light and hold a measuring tape and accurately measure, because you're not supposed to hold the light right on the patient's eye. It's a flicker. You're stimulating a reflex, okay? So you want to be doing this. But you know, the more times you do it, the patients are going to start to see spots in front of their eyes from all the light. So we want to get really good at this, and we want to be able to just do it a couple of times on each side to make sure we're seeing what we see. The more practice you have, you will get really good at reading them. And sometimes A lot of times you don't really need the gauge if you're doing your pupil assessments all of the time. You will know if it's a 6, a 7, or an 8, but you should have a chart to compare. Don't guess. You're going to be documenting if they're normal. No, I'm not going to say that right now. I'm going to stop that. I'm going to talk about documentation after. Okay? So I'm going to be bringing the light over, bringing the light to the other side, bringing the light again. You get your patient to look straight ahead at a fixed thing and try not to blink. And you're going to be doing your assessment. Please be down in front of them. You can't flash the pupillary and be completely above them or arm's length away from them, just like the picture is. And if your patient can't really hold their eye open or they blink every time you do it, just gently hold their lids open a bit. So even if they do blink, you still should be able to do the light. Okay? That's pupils. As you're doing that, you're checking that they're equal, and they're equal in size when they're unconstricted and so dilated, and when they're constricted. Are they equal? And they should be equal bilaterally without light stimulus and with light stimulus. You should be getting the same numbers on each side. Pardon me, your pupils should be round. That's normally. You will see with different eye disease, if they've had cataracts, if they've had eye trauma, but also potentially some neurological damage. You can have some misshapen pupils. And they're very obvious when you see them. You'll go in and you'll go, oh, because scar tissue could build up. Different things happen. So your patient usually, you may already know that in their history, but patients will usually say, oh yes, I had a ball in the eye when I was 14 and, blah, blah, blah. And they'll have a little story for you. But normally, all of us will have round bilateral pupils. That's a normal finding. Conditions I didn't finish my sentence. Conditions may alter this, meaning medical conditions or surgical conditions. Then the next part is it reactive to light? So you are assessing that when you're looking for your size of your pupils. But what you're also going to be documenting is that they did react to light. Sometimes you will get an eye that will not react to light. And we have to specifically indicate that. Because just telling the size of pupils doesn't always let the person reading your notes know that those sizes also, happened with light reaction. You can have different sizes and still have light reaction or no light reaction. I've had a patient, 2 of them in the past. One was very kind and let me know ahead of time they had a glass eye. I was admitting them. The second one, man, thought it was funny to see if I could figure it out. So here you are, because some glass eyes are pretty good. And it's like, why is that not reacting? Then all of a sudden, my brain went. And before I started to say, he said, it's glass, dear. But you can have a non-reactive pupil that could be normal for someone, but it also can indicate an abnormality potentially with the optic nerve of that eye. The last one that we assess, the last piece of the acronym, I should say, is accommodation. Accommodation is, again, another test on optic nerve focus and muscle function of the eye and brain response. What you do is I just take the same pen light I have, or a pen, or your finger. You're going to get your patient to, have your patient look, just put it a couple of feet ahead, and have your patient just focus on the object, and you're going to slowly move it in towards them, and you're going to be watching them focus in. And what happens as it gets closer, as you see in the picture, that made me dizzy, They'll go a little cross-eyed, and the eyes should move towards the nose equally, and the pupils should constrict equally. And we call that accommodation. And that is also testing neurological and ophthalmic status of the eye and one of the cranial nerves. So if everything is normal, you've had normal findings, you would simply chart in your patient's chart, Perla is normal. Some charting would actually get you to chart beside each acronym. So pupils, equal. Pupils, normal, equal bilaterally, round, reactive to light, accommodation. So you may be typing those words in, you may be checking those words. They're all different. Those are normal findings. Then what we would do, if they aren't normal, you're going to indicate in that piece of charting exactly what's abnormal. So for example, I may say pupils are normal and equal in size. I always chart my size 3 millimeters without light, constricted to 1 millimeter with light. I think it's good to have that in there. You should chart the sizes. They're equal bilaterally. The left eye pupil is round. The right eye pupil is oval due to whatever the reason is. If you don't know the reason, you just chart it's oval. Patient states was born this way. Patient states it happened when they were a teenager. Patient states they have this condition. Okay? You put in what you know and what you've assessed. Are they, again, are they reactive to light? Oh, I got to talk about consensual constriction here. Sorry, people. They reactive to light? Yes. Equally? Yes. And then accommodation. And again, if they don't accommodate, we state it. You could say accommodation. Left eye does not fully accommodate with the right eye when tested. That's what we'd say. Pupils do not constrict equally when accommodation tested. And this will be our practice charting, but it gives you an idea of what we're going to be indicating. The other thing with reactive to light, you want to make sure not only are your pupils constricting when you are initiating a light onto them. The other piece of the brain, because constriction is a protection of the eye from bright light, right? They constrict in daylight and they open up wide at night. It's to help us see, and it also is to protect us from UV rays, for example. Even though I am flashing the light on my right eye, my left eye is constricting. It might not be constricting as much, but they talk to each other. The brain tells the eyes, uh-oh, there's a bright light on the right, left eye, get ready, basically. And so when you're looking, you're not just looking to see, are they constricting equally? What size are they constricting down to? Are they bilaterally equal? And is consensual light reflex present? Okay, so when I flash the light here, is this constricting? And you guys are going to do it to each other, and it's really, when you see it, you're going to go, for heaven's sake, right? And you're going to do that. So normal finding is that you have consensual light reflex in both eyes, or you could say that you have a consensual light reflex in the right eye only, which means the right eye is the only one that will constrict when light is put in the opposite eye. So that is a consensual light reflex, and we all have it. The eyes work as a pair. So, hand strength, motor function. I said I was going to get into a little bit more of the strengths, and I'm going to specifically talk about what you may know and have heard before are pushes and pulls on the feet, and grips, hand grips, and sort of extremity strength on the arms. This, not just with your patient being able to do the moving, you are also going to test their ability to demonstrate this strength that they have in their extremities. So your patient can be lying down or they can be sitting, it doesn't matter. But what we are going to be doing, first of all, we're going to do hand grips. That's what we call them. You can hold, pardon me, I've got them opposite down here. Kimberly, you want to go? Just going to get my little, let's do bright blue here. So down here are our grips. What you're going to do is get your patient to hold your hand here in front of them, and you're going to ask them to squeeze your hands at the same time. So, you know, you're holding their hand and they're squeezing. What we're assessing is, first of all, are they doing it equally, and is the strength equal? And also, this is another little test of, can they follow commands? So are they following commands? They're squeezing equally, and they're letting go when you tell them. And that would mean that they've got good hand grips. Two things that you're really assessing is, are they strong or weak? And are they equal? So you may have your patient squeeze your hand, but the left hand is gripping me stronger than the right. So right there, the left grip is greater than the right grip, is how we will put it. But don't just stop there. Say, can you squeeze your right hand just a little tighter? Squeeze, 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 squeeze. Some people with command and focus can make the weaker grip stronger by doing that. But we don't credit them with good hand grips. What we say is, the right hand grip is weaker than the left, or the left is stronger than the right, each way is fine, and that you can increase the strength of the right hand grip with commands. It's important to say that, because that's testing commands and it's also testing strength. But that is still indicating a delay talking to the right side of my body. Okay? The other thing you want to test is pushes and pulls of the arm. So there's a few different ways to do this. We're going to show you. It's also nice to modify it depending on your patient. So the top one is fairly common, especially if you've got, you know, younger, stronger people. It's more about, can you push me away? Pushes and pulls is about, you know, are you able to hold down and push away, is basically what we're doing. So I'm going to try to demo here, but basically, so let's look at this picture here at the bottom. We'll look at this one. This is just an alternative. We're doing the same test, it's just we're just doing it at the wrists and below the wrist, really. You don't ever hold on to a joint below the wrist. And we're doing it the same way. But this isn't for everyone, this top one. You got to think about your little frail people with arthritis in their joints. I find we can be a little bit rougher with that one, but it's not wrong to use. You will see it out there. So what that means is, let's say that my patient's arm is on the bed. So this is me laying in bed, my arm's on the bed, or it's on a table. And I'm just going to tell my patient, now, when I put pressure on your arm, I want you to try to push against my hand and lift your arm up. Okay? So this is checking your arm strength by pushing away. Okay? So you're going to do it and say, okay, you put some strength, and they try to lift. And what you want to feel is a really good effort they're pushing, not just or nothing. They give up. So, and I usually do arms bilaterally. We're going to show you how to position yourself in lab. You should do them at the same time. Again, coach them if one seems weaker than the other to see if you can stimulate a stronger reflex. So they're trying to push away. And some people that excuse me, and some patients may find that uncomfortable if you're pushing too hard, and they can't, but it's testing their strength to push away. Then the other one is you're going to snuggle your hand under the mattress, and you're going, I mean, pushes and pulls. I probably say them opposite, but you're pushing and pulling. So what you're going to do then is, can they push my hand away? Can I put my hand under? And I'm going to then try to push their arm up, and can they press it down onto the mattress? Okay, so I would give pressure, try to lift up their arm, and this is testing muscle resistance, strength resistance. So my hand is now under them on the mattress, I'm applying pressure and they're pushing down. My hand, it's resting on the mattress, my hand goes above and I put pressure down and they're pushing off. Okay? Pulls are the other way. There's a couple of ways to do them, but basically, can they, if you see in the picture on the top here, this young fella's got a very determined look. Do you see that? It's very serious. Again, can you pull? So it's a little difficult to demonstrate unless we do it in lab, but again, so you're giving resistance. I'm wrapping my arms around, okay, try to pull me this way and try to pull me that way. And again, this is about muscle strength, the muscles. The others is resistance testing. They're done. It just takes seconds. So you're going to, okay, push against, okay, push against, okay, pull. So they're pulling and pushing against a resistance. And then your hand grips. So hand grips, pulls and pushes of the upper extremity. We are looking for strength. So we want to say they're strong, symmetry, they're equal of the upper extremities. And we will categorize them. You will do hand grips, strong and equal bilaterally, upper extremity pushes and pulls, strong and equal bilaterally. Those would be your normal findings. Now we go to the lower extremities. These are probably a little bit more common. People forget to do the strength in the upper extremities, but it's important. You've got patients with arthritis. You have patients that have had strokes. The upper extremities get impaired just as easily as the legs do. So it might be a little new for you to be thinking about doing this, but we do this very commonly on our patients in their lower extremities. So again, it's the same things we're doing. We're testing for pushes and pulls, and we're testing for resistance strength on the legs. So back to some little medical terminology for you. You need to know dorsiflexion, and you need to know plantar flexion. So if you think about the foot, so this is my hand, pretend it's a foot, I got very long toes. You have your foot. The foot in neutral position is just that. But when I lift my toes to the ceiling, that's dorsiflexion. So think the dorsal side is lifting. And then from neutral, you push down, you bend down, is plantar flexion. And think of planting your foot, the plantar side. So plantar flexion. So we have neutral foot position, dorsiflexion, and plantar flexion. And we're going to use those range of motion terms to initiate our assessment and tell the patient how to do. So what we're going to do is test pushes, foot pushes and pulls of the feet, just like we did hand grips. We're going to do foot pushes and pulls. And what we're going to do is stand at the end of the bed, and we are gently, first of all, going to put our hands on the top of each foot. You should have the patient have their foot in as neutral of a position as it can be. And then you're gently going to put your hands on the top, and you're going to get them to dorsiflex. And as they're trying to dorsiflex, push their toes up to the ceiling, you're putting some pressure. It doesn't have to be, by the way, a game or a competition. They don't have to like kick your hands off their feet. You just want to be able to feel the strength Is it strong? Is it equal bilaterally? If one is weaker than the other, can I coach them? Can they verbally respond to commands to make it stronger? Okay, so you're assessing that. Then you're going to go opposite and you're going to put your hands on the bottoms of their feet and get them to push down. I always say push down like you're putting on a gas pedal, and get them to push down with your hands this way. And again, you're assessing for equal strength, strong strength and equal bilaterally, the same things. So normal findings and how we would chart: foot pushes and pulls, strong bilaterally and equal, or equal and strong bilaterally, however you work it. Okay? We do the same with the upper extremity, or we take the technique we have for the upper extremity for the arms, and we are going to apply it to the legs for your resistance strength. So what we're going to do, have, again, just upper leg is the best, people, just because that's where our biggest, strongest muscles are. And it's an unfair disadvantage if you kind of go towards the lower legs or the feet and hold them. You're actually holding the extremity down, not creating an atmosphere for testing resistance. Does that make sense? Because it's a smaller part of the leg, and we will be pushing it down harder. So it's an unfair test. It should be on the upper part of the leg or on either side of the kneecap, whichever way you want to do it. But generally you're going to see hand position there, just above the knee, and on the upper leg, pardon me. Same thing as the arm. Apply pressure. We use two hands. Apply pressure because it's a longer extremity. That's why. Apply, moderate pressure and get your patient to try to lift their leg. Lift your hands off of them. You're checking that bilaterally, but you're going to have to do it separately because we do use two hands. With the upper arms, we can put our hands on both arms and get them to do it. Leg, we have to do one at a time, but we do them back to back, which is bilateral enough, right? You're sort of within the same moment of time. And then you're going to slide your hands under their leg against the mattress. And as you apply pressure up on the leg, they're trying to keep your hand down. Okay? So on top of the leg, you say to your patient, try to push up against my hand as you create pressure. Then you're going to go under the mattress and you're going to be pushing up and ask them to, I always say, push my hand into the mattress. That's what I say to them. Keep my hands into the mattress. Don't let me lift up. Again, looking for equal bilateral strength for pushes and pull resistance. So normal findings you would chart. Lower extremity resistance. You could say, okay, you could do two things. Lower extremity strength resistance equals strong bilaterally, or you could say lower extremity pushes and pulls equal and strong bilaterally. Both are correct. I flubbed over the words because I always charted lower extremity resistance. So saying pushes and pulls for the leg throws me off, but either way is correct. I think I got everything. Let me just double check my little box in here. The raises, and really I guess leg raises, you're wanting them to raise. The other thing with your extremity check, I should say, don't have it so that they've got their knees bent and their feet. Their leg has to be straight out as much as they can tolerate. So orientation status. Orientation status is a piece of the verbal response part that we are attesting for. And we're going to talk about this specifically because it's an amazing little tool. And it's one of the very first little sets of questions and tests we do to check for some potential confusion. Okay? Fancily said, we're checking their cognitive state, their cognition, and what status they're at. We're always testing person, place, and time. You will see some literature now say event or circumstance, I believe. That is not around here, and in our books we're following this. But really, person, place, and time should be enough for you to determine, okay, they're a little bit off in knowing where they are or who they are or what time it is. Okay? The goal is our person should be orientated to person, place, and time. So what that means, if a person is orientated, we ask them open-ended questions, not close-ended, because you don't want yeses or nos. That doesn't test anything. You want them to be able to give you an expected answer. So first thing, person. You don't say, who am I? It's them. Do they know who they are? And we're not, what we do is very easily, hi, how are you today? And you've already done your thing and you've already called them George. But we start, and I usually say, okay, I'm going to ask you 3 questions to test your memory. Or I just say, I'm going to ask you 3 questions to test your brain power. Like, I kind of make it a little game sometimes, because some of them will say, if I say to them, now can you please tell me your name? They'll say, you know my name, you've been calling me my name. We want to make these easy to get answers. So the first thing I will do is say, can you tell me your full name? Because I may have been calling them Gladys, but not Gladys Smith. Gladys Smith. Okay. They know their name. So they're orientated times 1. Now, place. Do they know where they are? Now, I have learned, many nurses have learned over the years, I no longer say, do you know where you are? Because even a confused person could look around and figure out they're in a hospital. Try not to let them give you vague answers. I really do say, do you know what city we currently are in? Don't say, what city are you from? Because they may be from Edmonton. And you go, oh, we're in St. John, and they said Edmonton. No, you ask them where they're from, and they're telling you they're from Edmonton. That's right. So again, be very, very careful. Pick your 3 questions that you always ask. So what I always ask is, and don't say, do you know? I just say, please tell me the name of the city that we're currently in. And if they're, I said, well, what about the province? Do you know the province? Yes, it's New Brunswick. Okay, we'll take that, because guess what? They may also be from Graham and Ann, not St. John, were brought here by ambulance and don't completely know where they are. They're still mixed up. So we don't want to trick them. We want to give them a fair question. But I always do the city. I know some of my colleagues would say province. And then if you want to say, very good, it is New Brunswick. Do you know the city? You could go that way. But you don't have to drill them with 10 questions. Find one that works the best and use that. If you're not getting a correct answer, you should ask them a second one, just in case they are, and if you say to them, it's probably not this way much anymore, but in the early 80s, we opened the regional hospital, and patients had been to the general hospital before that. That's what it was, the St. John General Hospital. So if we would say to them, can you tell us the name of the hospital? Most of them would say it's the general hospital, because they still hadn't gotten used to the new hospital, right? So just be a little bit creative with your questions. You want to make sure you are determining really good orientation status. So first thing I ask is, would you please tell me your full name? First and last name. What is the name of the city we are currently in? And 3, this one is tricky. They don't know what time it is. They've been in the hospital, and unless they got a clock in front of them, they don't know. Time is not time on the clock. Time is the day of the week, or the date, or the month, or the season. Okay, so sort of what time of our journey are we in, not what's the time on the clock. So don't ask them, can you tell me the time? Half the time, I don't know the time. So that's not a fair question. Again, I usually say, do you know what day of the week this is? I do start with that one. Again, the date. I came in this morning and said, I know it's Thursday, but I sat down, I'm turning on my computer, my brain's going, okay, what's the date today? What's the date? What's the date? What's the date? It's Thursday, it's the 4th, right? Okay, do you know what I mean? So even think about yourself. I find, this is me personally, I find people, especially they've been in the hospital, can at least keep track of it 24 hours, like, okay, yesterday was Tuesday, today is Wednesday. The date, maybe not so much, okay? If they cannot tell you the day, they're not going to be able to tell you the date. But then you may say, okay, fair question, you've been in the hospital for a little bit. Could you tell me though what month this is? And they say, oh, it's September. They're orientated to time. Sometimes we have to ask the season. Okay? So, hi, I'm going to ask you a couple of questions. Will you please tell me your full name? Kimberly Ellis. Can you please tell me what city we currently are in? St. John, New Brunswick. And can you tell me the day of the week? It is today. It's Thursday. Wonderful. I passed. I am what we call orientated times 3. This is the approved, charitable, everybody's going to know, capital ORT times 3 means your patient is orientated to person, place, and time. It is not wrong. If you want to write that out longer and say orientated to person, place, and time. But what happens if they're not orientated to one or more of these? Then we're going to be specific. What we chart is what they are orientated to. So under cognition status, under where orientation is, let's just say they knew their name and they knew the city, but they had no idea the day, the month, the season, they just didn't know. Then we are going to say that she is orientated to name and place. We automatically know that time they weren't orientated to. If you wanted to be more detailed and do it a step further, you could add orientated to name and place, comma, not to time. That's okay. But this is accepted just to state what they are orientated to. By default, we know what they aren't orientated to. And the last one, if they're only orientated to one of these, they only know their name, but they don't know where they are or when it is, then we would state just what they're orientated to only. So they were orientated to name only, place and time, we know that they don't know. And this gives us the degrees of their confusion. Okay? Sometimes they're not orientated to anything, and we put that. Actually, we will write it right out. Not orientated to person or place or time. We really do put it right out there. I probably should have written that there. We will put that out. Okay? So that's orientation status. Normal findings should be orientated times 3. Otherwise, we're specific to what they are orientated to, and by fault, they're not orientated to what we didn't chart. The last piece for this will tie into the eye-opening piece. This ties into the verbal response. And in a way, it will tie into your motor response. Orientation status and level of consciousness are different. Orientation status will come into play a little bit, but this is really being more focused on how awake or how asleep my brain is. Not my cognition, not my ability to process information and appropriately communicate back. This is about the actual physical functioning and alertness, awakeness, or awareness of the brain. Okay? AVPU is a great acronym. It isn't in your textbook. We still put it on the slides for those of you that like acronyms. AVPU, I think some people say. I just say AVPU. Alert, verbal, pain, unresponsive. Those are the 4 things that we really are looking at. And we've already talked about them when we did the slide before, just talking about basic neuroassessment. Pieces of that are in here. So when we do our grips and push, when we do our hand grips, foot pushes and pulls, upper and lower extremity resistance testing, we do our PERLA, we do our orientation status, and then we test our level of consciousness. All of those pieces tested that chart that was on the very beginning. We will be covering all of those findings by doing these tools, which is what these are, tools that we use. So what is a level of unconsciousness mostly monitoring for? Intracranial pressure, mostly, due to very, very many things. Sometimes, however, level of consciousness will change with certain disease conditions. It will change with oxygen levels. It changes with many things. I don't want you to think ICP, we call it, I don't want you to think increase in cranial pressure is the only thing. It just happens to be on from this resource, but we're monitoring the awakeness, alertness of the brain, and whatever the reason is, the level of conscious status needs to be assessed. Okay, so it's not just ICP. So again, orientation status that we just did is part of it, because are they alert and are they awake and are they answering questions? That verbal response. You give them 3 quick questions. That orientation status is testing cognition, but it's also testing if they're awake and able to answer questions for you. Are they alert? So what this means is alertness. Alertness means, are you aware? Alert does not mean, are they aware, or are they sleepy? Are they drowsy? Or are they completely out cold, which we call unresponsive? So that is what we're mainly doing with level of consciousness. And again, it goes back to, are they opening their eyes as soon as I come into the room? That's very alert and aware, because they heard me and they opened their eyes. Do I have to call their name or say excuse me or good morning, and they open their eyes again? They were deeper asleep, but they're awake and alert to speech. Or do I have to then go over touch stimulus, or do I have to initiate a pain stimulus, or I'm doing whatever I can and they're not waking up? That is what it is. Are they alert and awake? I would ask this question in class. I'm going to ask it now for you to think for a second. Do you think a patient can be alert, be conscious, and be confused? The answer is yes. Some people struggle with that. This just means I'm awake, and you think about your confused patients. They're busy, they're awake, they're moving around, they're seeing people, they're doing stuff, they're getting dressed, they're busy and alert, but they have no idea who they are, where they are, or what time it is. They're fully confused, but they can be alert. So I want you to kind of process that. All right, that is why I kind of highlighted the orientation status piece, focused on confusion and the ability to communicate. Level of consciousness is focusing on the awakeness and alertness of my brain. So are they alert? And if they're not, what does it take to make them alert? Do you have to call their name? Do you have to do that light touch? Do you have to do a vigorous touch, like give them a little shake? Or do you have to initiate pain? You know, pinching the fingernail, doing a sternal rub, giving a little pinch. Don't do it hard. Don't hurt them. But sometimes we have to do a deep pain stimulus, and that is our good old sternal rub to wake them up. Think of those patients that, you know, are have a lot of opioids on board and they're passed out. But we can stimulate a deep pain response, so that means they're still in there. The brain is still responding to external stimuli, but they're really, you know, not on a really good, strong alert status, right? So we go from being alert all by themselves, verbal stimuli, hey you, how are you, maybe knocking on the door, making a little noise. That's why we do that. And then, okay, that's not making them wake up, little ouch, little painful stimulus. And then are we determining them to be unresponsive? And one thing you can, normal finding with level of consciousness, you will see commonly that orientation status could be included with it. You'll see it a lot. But you could just put level of consciousness, they're alert, responds to verbal stimuli, they're alert to painful stimuli. You know, you're going to kind of put, yeah, I can wake them up, but I have to initiate a pain response. So there's all different levels of charting that we're going to practice in lab. But we really want to make sure that you are aware orientation status and level of consciousness are assessed separately because they are testing for 2 different types of brain function. That is the end of neurovital signs and your little basic neuro assessment. We're going to be doing these on each other. It's not really invasive, and as you're actually initiating these responses, they're going to make so much more sense to you. Again, there is a video that will be put up in your Bright Space course, in the lab course, on how to do neurovitals, if I can find one that only has these pieces. So I'm telling you right now that what may happen in lab is we will do a full demo first, because I'm struggling to find one that doesn't have extra stuff in it that you don't need right now, and I don't want to confuse what you need to know at this level. So as always, have a great day, enjoy this little video, and we'll see you when I see you.